Hello, and welcome to the first in our series of mental health interpretation. This first course will focus on the role of the mental health interpreter. So, we'll be comparing and contrasting the role of the medical interpreter as set forth by the NCIHC, the National Council on Interpreters in Healthcare. And we'll be kind of building off of those roles of the medical interpreter and relating them to mental health interpretation. So, my name is Kelly Grzech. I am a certified medical interpreter. I'm a Spanish interpreter. I'm certified by the NBCMI, the National Board of Certification for Medical Interpreters. I also have my bachelor's in foreign language
with a concentration in Spanish.
and I also completed the SETI program, which is the Spanish English Translation and Interpretation program at Virginia Commonwealth University. I consider myself to be a mental health advocate in the interpreting community, not just for ourselves as interpreters, but also advocating for the population that we interpret for, limited English proficient patients, patients who need to utilize an interpreter. And I do that by means of providing some more robust training and educational materials to interpreters so they can be more effective mental health interpreters because unfortunately there is no national certification for mental health interpretation at this point. And this is something that medical interpreters are often tasked with. And medical interpreters oftentimes don't have sufficient preparation for what mental health interpretation often entails. So, this course has been designed to give kind of an intensive look into mental health interpretation and to give more of an intensive training course versus these 1 hour CEUs that we occasionally have here and there. So, beginning, we have these 4 roles of the medical interpreter as laid out by the NCIHC. Now, our default role is the conduit role, where we're simply facilitating communication. Then we move on to the clarifier, the cultural broker, and the advocate. I believe the CHIA, the California Healthcare Interpreter Association, also has a similar definitions for the roles of a medical interpreter. They have slightly different names, but generally the same responsibilities. Now, as we progress through these roles, we start off in the conduit role. Once we start moving into the clarifier role, the cultural broker role, the advocate role, which is the most involved role, we increase involvement as we move up in this scale. And hot take, this is my view on these roles as they pertain to mental health interpretation. The core responsibilities in each of these roles are actually more involved in mental health interpretation. And as a result, the interpreter needs to exert far more caution when progressing through these roles, progressing to more involved roles in mental health interpreting. So we'll start off with the conduit role. We'll be talking about this role quite a bit. It will take up the majority of this presentation, and it will also appear in further installations of this series. Because if we're exerting more caution in progressing to other roles, we're going to stay in this role the majority of the time, even more so in mental health interpreting. And it gets more complex in mental health interpretation as well. So the conduit role is interpreting accurately and completely. It's the default role, it's facilitating communication. So accuracy, when being the conduit in medical interpretation. If a patient says, "My stomach hurts," what does the interpreter say? Well, I don't presume to know your target language, but what you say in your target language should be something along the lines of, "My stomach hurts." That's it. It's simple, right? Yes, it's simple, but unfortunately, I have heard many interpreters interpret these things incorrectly. Instead of saying, "My stomach hurts," they may say, "My belly hurts," or "My tummy hurts," even "My intestines hurt," or "My lower esophageal sphincter hurts." Okay, I'm not going to lie, I haven't heard anyone say "My lower esophageal sphincter hurts," but these are all terms that are different registers. So we have to interpret register for register, word for word, concept for concept. And I'm going over these kind of basic things because these are the foundations upon which we build the rest of our interpretations. We build the rest of our skills as an interpreter. Accuracy is incredibly important, and we need to match register. Register matters, and there is a hierarchy of register. So obviously these terms all don't mean the same thing. Your lower esophageal sphincter, if you even know what that is, which I don't blame you if you don't, that is not the same thing as your stomach. Your intestines are not your stomach. And it is likely in some cultures that patients will use intestines instead of stomach to describe stomach pain. So we do have, using the previous terms on the previous slide, a hierarchy of register, right? So we're going to have the more complex terms at the top, the less complex terms at the bottom. So obviously lower esophageal sphincter would be the highest register of all these terms. Intestines, stomach, maybe on the same level in some languages, some cultures, but definitely the lowest register are going to be tummy or belly. So of course, patients who may have a lower level of education, patients who, let's say pediatric patient, they will typically use the words tummy and belly to refer to the stomach area. You may think that this is not important. I certainly hope you don't, but it is very important because when we have a patient using a term like blood glucose, that's very different from blood sugar. Now, they mean the same thing. However, it clues the provider into the patient's health literacy. So if they're talking about their shoulder blade, they're saying scapula. That gives the provider a clue that maybe this patient knows a little bit more about body parts, about anatomy, and they may not need to delve into as many explanations as they would with a patient who uses lower register terms. So a good interpreter will paint a picture of the patient's health literacy. Ideally, a good provider will pick up on these cues and match the patient's register. And they'll even decide how deep to delve into health education as they go. So if we're diagnosing a patient with diabetes and the patient is using high register medical terms, well, the provider likely won't need to get into a really deep explanation of what diabetes is. They might kind of skim across the surface. Whereas a patient who doesn't understand what blood sugar is, obviously that provider is going to have to go into a little bit of a deeper explanation. So we've gone over accuracy. Now let's get into completeness. So when being a conduit in medical interpretation, completeness is the second piece of the puzzle, right? So if a patient says, "My stomach, ow, it really hurts," you need to interpret everything that is said and not give a summary. So you need to say, "My stomach, ow, it really hurts." You need to match it. You need to add all those little extra clues in there. You need to add ow. You need to add it really hurts. Because if you leave out these little extra bits, they're going to give the provider a false impression as to the level of the patient's pain. And the provider may match the level of treatment that they give the patient with the severity of the symptoms as they are described. So vice versa is bad too. If you say instead, let's say the patient says, "My stomach hurts," and then you add, "My stomach, it really hurts," you're changing the message, and that is not your responsibility as an interpreter. Now, moving on to mental health interpretation, when we talk about accuracy, everything that was previously said applies in mental health interpretation. However, accuracy gets a little bit more complicated. There are so many words we use to describe our feelings. And there are often these kind of seemingly insignificant, minute differences between these terms. So fulfilled versus content, mopey versus depressed, tense versus frightened, energetic versus manic, irritated versus furious. Those are all different things. They generally fall under these umbrellas of happy, sad, scared, excited, angry, but there are small, minute differences between these. So I'll ask you, how many of these terms do you know in your target language? Realistically, for mental health interpretation, you need to know them all. And it can be a little bit difficult. especially if the language that you interpret into, your target language, doesn't have as many words to describe things. So you really need to know how to express these differences. So just as a medical interpreter needs to know 1,000,001 different ways to describe physical pain, for instance, mental health interpreters need to know 1,000,001 different ways to express 1,000,001 different emotions that a patient might be feeling. Now, you can get by, quote unquote, I hate that, but you can, quote unquote, get by as a medical interpreter only knowing a few ways to express one concept. But mental health interpreting is far more demanding. So, accuracy in mental health interpretation, when we talk about the provider, because we have the patient, we need to know how to express their feelings. We also have the provider. And you'll come to encounter that mental health care providers tends to be very purposeful in their use of certain words, certain phrases, even nonverbal cues. You will generally tend to find, now this is not always the case, but this is usually part of a mental health care professional's training, is employing affirming and respectful speech. So the first of which, and these are just some examples, this is not an all-inclusive list, but these were the most apparent examples that I could think of. Person first language. So what is person first language? Well, person first language is putting the person first. Instead of saying a schizophrenic, that dehumanizes someone. That reduces someone to their condition. It's perhaps better to say a person with schizophrenia. Now, if the mental health care provider that you're interpreting for says a schizophrenic, you have to say that. But if a mental health care provider purposefully chooses the phrase a person with schizophrenia, it is your responsibility to mirror that person first language. The same goes for sexual orientations. Now, the word homosexual, of course, has many negative connotations, especially when used as a noun. And then we add in additionally that you're simply reducing someone to their sexuality, whereas a mental health care provider may say a gay man. If the provider says a gay man, you cannot interpret that as a homosexual because that will have additional connotations, and that also is not reflecting the provider's use of person first language. Another way in which providers are affirming and respectful, many times they try to avoid ableist language. Ableist language is language that is offensive to people with disabilities, whether they be physical or mental. So, a schizophrenic would be ableist language. Just like saying, that's crazy. That's not typically something that you're going to hear from a mental health care provider. I have heard it before. But if a mental health care provider says something along the lines of, that's outrageous, it's important not to interpret it in an ableist way by saying that's crazy. Because I will tell you, using words like crazy, insane, these are all words that, in my personal and professional opinion, do not belong in a mental health care environment. Instead of saying, that's dumb, a mental health care provider might say something along the lines of, that makes no sense. That's nonsensical. Dumb is ableist language, and you want to avoid using that if the provider is not using it. Now, if the provider says that's dumb, by all means, interpret it as that's dumb. But if the provider says that makes no sense, you should not be interpreting it as that's dumb. One more example is utilizing gender neutral and or gender inclusive language. So gender neutral language is language that is not referential to gender, whether it be male, whether it be female, whether it be something outside of the gender binary, which is masculine and feminine. So gender neutral would be using, for example, in English, the singular they, which has existed for quite some time. The singular they has no gender. It's not male, it's not female. It could be, but it does not expressly express gender. Whereas gender inclusive language is language such as police men and women. And why does this matter? Well, as I will get into in a later installation of this series, the LGBTQ population has a mental health crisis as a result of being a marginalized population. And you will find, and this is what I have found, anecdotal evidence, that my interactions with the LGBTQ population, the LGBTQ LEP population, the LGBTQ Spanish-speaking population, the majority of those interactions that I have when carrying out my professional duties occur in mental health spaces. So, when stepping into a mental health care space, you need to be prepared to navigate gender and sexuality in a non-judgmental way, because ultimately that is your responsibility. It is your responsibility to stay abreast of terms pertaining to gender and sexuality. So a provider, even if they are not seeing to a patient who is a member of the LGBTQ community, they may ask a patient what their pronouns are, because the majority of the mental health spaces in which I interpret often have stickers or flyers or pamphlets explaining that they are an LGBTQ safe space, because they know that this population is trying to seek out a space in which they are accepted and their identity is affirmed. So it is important, if a provider does use gender neutral or gender inclusive language, or if they're explaining terms about sexuality or including terms about gender, you must know how to interpret these terms. And if the provider is using these terms in an affirming way, you need to know how to interpret them in an affirming way. If they are using the terms in a disrespectful way, you have to interpret them in a disrespectful way. Now, all of this being said, there is something worth mentioning when it comes to the intersection of person first and ableist language. Certain communities and certain individuals in certain communities, such as the deaf community or the autistic community, they may avoid person first language. And why do they do this? Well, they do this because their condition is a central part of their identity, and they don't want people to use person first language with them. Now, this is why it's important to follow cues from the provider, because in many cases, the provider will likely have existing rapport with the patient. And so they're more aware of the patient's preferences. So you definitely need to mirror the provider's speech as an interpreter. That's your responsibility. So follow the provider's lead. Another tool that mental health professionals use when interacting with patients is reflective or active listening. Now, there are different strategies under this umbrella, the first of which is minimal verbal responses. These can be sounds, they can be things like, might even be short little teeny tiny phrases like, I see, I understand. All of these signals express that the provider is listening. Another tool is reflecting or echoing. This is a tactic that mental health care providers employ to basically show that they're listening and show understanding, putting things into context, but it's not an analysis, so they're not adding anything. It may seem redundant to repeat back exactly what the patient just said, but it's something that mental health care providers do. Paraphrasing. We all know what paraphrasing is. So it's kind of a shortened version of what was just said. It is another tool that mental health care providers use to show that they're understanding what the person is saying and that they're also paying attention. Now, moving on to summarizing. Summarizing can be the joining together of a bunch of different paraphrases. So if you have an entire, let's say, therapy session, and the provider will pull paraphrases out from different points of the session, join them together in this summary, and they may be using this to show the patient a pattern in their behavior. Another very important component of accuracy in mental health interpretation is tone of voice. So, of course, you need to reflect the patient's tone, because the patient's tone can be a diagnostic tool, especially if they have an incongruent tone of voice with what they're expressing. If a patient expresses that they're depressed, but the way that they express it through their tone of voice is that they're happy or they're elated, two different words that you need to know how to interpret, that can be an important diagnostic tool for the provider. Tone can also change the meaning of an utterance. Oh, yeah, sure, I'll totally do that. Versus, oh, yeah, sure, I'll totally do that. Those two phrases, despite the fact that they have the same words, can mean two different things. One says that that person's really going to do the thing. The other one says that the person really probably isn't going to do the thing. And a patient's tone can change over the course of the utterance, no matter how long that utterance is. It can be a very long utterance and have ebbs and flows and peaks and valleys, or even over the course of a single sentence, tone can change drastically, especially if a patient is unstable. And that is another important diagnostic tool for the provider. Now, the provider is often very particular with the tone that they choose to take when interacting with a patient. Now, the tone that a provider takes can be highly dependent upon the patient. So it can be on a case-by-case basis. It can even be on a situation-by-situation basis with the same patient. But the fact is that a provider's tone, as with most tools that they use in their toolbox, they're often laden with intentionality. They are very intentional when it comes to their tone, more often than not. So I found this amazing article on Psychology Today, and it is by Jean Kim, who is a medical doctor in some capacity. But they were talking about the way that they use their tone of voice, the way that they use their voice when working with patients with mental health conditions. So I have a short excerpt here, but I'm going to read from the article, which it paints you such a detailed picture as to how mental health care providers utilize their voice and their tone of voice and how intentional it can be. Jean Kim says, "I found my voice changing, harmonizing the despair I heard, confident and reassuring for the depressive, who was often brittle and disconnected, fresh off of a suicide attempt. Flat, monotonous, gentle to approach the terrified paranoiac, where even a glancing half laugh would set them off. Tough and unflappable for the charming manic, who loved to draw more glee and less discipline out of those around them. I even had to display strategic, tart authority for the wavering manipulations of someone with a personality disorder. My voice settled into a rhythm, my signature sound. I used its inherent softness to approach someone without threat, without insistence. But I backed it up with a hint of gravitas, to give credence to the seriousness of my patient's crises, to empathize with tragedy. I kept my intonation smooth, calm, controlled, to offer security. I would explain how together we could sail forward across currents of pain, and I could see their frightened affects soften with relief, that my speech offered solid ground." Wow. So that really gives you some insight into how a mental health care provider purposefully chooses their tone and how that tone can offer different things for different patients. So that's why it's incredibly important to be reflective of a provider's tone when interpreting, because the tone that they choose is very intentional and is designed to have an intentional effect. And if you change that tone, you're not conveying the message completely. Now, moving on to completeness, we've gone over accuracy. Now we're going to talk about completeness in mental health interpretation. Completeness also involves the use of a few different things. Nonverbal cues. Now, this is not just for the patient, but also for the provider. Pauses and silence. A patient may pause to indicate hesitation, pause to think, or they may just remain in silence because they don't know how to answer or they're thinking. Again, not an all-inclusive list, but some examples. A provider may use pauses or silence as a tool, again, laden with intentionality. They might offer a pause after saying something to give the patient an opportunity to interject. They may utilize silence to see if the patient has anything else that they would like to share. And these may occur in the middle of utterances. We also have disfluency. Now, providers can show some disfluency in their speech, and it is important for us to completely interpret disfluency. But for the patient, we need to pay special attention. So disfluency are any kind of interruptions in speech. So if someone says, if they start correcting something that they previously said, they make a mistake and then decide to go back and correct it. And this is where those Freudian slips come into play, where you say what you really mean first, and it just kind of comes out, and then you go back and you try and correct it. And those Freudian slips can actually be incredibly important because oftentimes our brain works faster than our mouths. And then we have those false starts where someone starts saying something like, "Oh yeah, I was at the grocery store and stop. Well, what I mean to say is I was with my cousin." So those false starts are where you start saying one thing, you stop, and then you say something else. These are all things that we need to interpret because you're not painting a complete picture. I keep on saying painting pictures, but that's what interpreting is all about, painting pictures with words and nonverbal cues. Speech patterns are another aspect that the mental health interpreter needs to interpret as well. And some of these speech patterns actually require different interpreting techniques, which in a later installation of the series, I will delve into more deeply. But different speech patterns that you may see in mental health interpreting. Rambling. Someone may just ramble on, and this happens in medical interpretation as well. So rambling is just one speech pattern that we have to interpret, and it may require the use of simultaneous interpretation, especially in mental health care settings, which again, I will get into in a later part of the series. Echolalia is a speech pattern in which a patient repeats certain noises or phrases they hear. For example, if the provider asks, "Are you feeling all right?" they may say, "Feeling all right?" And then if the provider asks, "Will you answer me, please?" they may repeat, "Answer me, please." It's not just common in certain mental health disorders, but it also occurs in children. Even children later on in childhood with developmental delays, adults with head trauma, it can even be a neurological symptom. So the use of these repetitive sounds is actually a symptom, or it could be a symptom. They could just be playing around. But this is actually a diagnostic tool for the provider because certain mental health care conditions actually involve the use of these abnormal speech patterns. Incoherent speech is another speech pattern, especially when you get into patients who have very severe mental health conditions. Sometimes patients just won't make sense. No amount of clarifying will give clarity to what the patient said. And so, in some way, this needs to be conveyed. But again, I will touch upon this later in another part of the series. We're going to talk about bad words. Because, like it or not, this is another aspect of completeness that we have to honor and be faithful with in our interpretations. I cannot tell you how many times I have seen this come up in conversations between interpreters on interpreting forums online or in conversations that I've had with other interpreters. How do you interpret bad words? Well, you just do. Interpreting bad words is part of your job. And when you're in these situations in a mental health care environment, we're talking about some pretty tough stuff. Patients will feel very strong emotions. And when people feel very strong emotions, they tend to use bad words. So you must know how to interpret these bad words. You must know how to interpret explicit things. You must be comfortable with interpreting explicit things. You're going to be interpreting for patients who are survivors of sexual abuse, of physical abuse, in some cases, survivors of torture. And you must be comfortable interpreting for these things because you never know what's going to come up in a mental health care interpreting assignment. When you interpret bad words, you do not omit them. You do not tone those words down because those will clue the provider in to just exactly how strongly the patient feels about what it is they're talking about. So let's move on to the pre-session. So a typical medical interpreting pre-session is, I don't even need to look at the screen for this one. My name is Kelly. I will be your Spanish interpreter today. Everything that is stated will be interpreted and kept confidential. Please speak directly to the patient. Boom. That is your typical medical interpreting pre-session. Now, how about a mental health interpretation pre-session? So a mental health interpreting pre-session will be all of the above, everything mentioned in the previous slide. However, ideally, especially if you are working in an inpatient facility, especially where you are working with acute cases, if a patient is admitted to an inpatient facility with a mental health condition, they are likely more of an acute case, or could even be a long-term case. And they likely have symptoms that make them unable to function out in the world. So those symptoms and those behaviors are something that I would say are essential to know about before stepping into the mental health care environment. So ideally, you should debrief with a provider or member of the care team before interacting with that patient, before interpreting for that patient. So in this picture, you see these two women sitting down. I don't think I've ever had a mental health pre-session where I've actually sat down with a provider. It usually happens in a hallway or in a waiting area or in an office, and it's usually a few minutes. So this pre-session is really important because the provider can give you a heads up about certain behaviors that may seem strange or even be problematic. I've had patients who do not respect physical boundaries and will even resort to touch. And so this is an important thing for the provider to let me know about before I start interpreting for that patient. The provider can even express preferences or certain strategies for working through these situations, especially since they likely already have rapport with this patient. For instance, a provider might tell you, my goodness, I wish a medical provider would let me know about this before an encounter. This patient tends to ramble. They're quite verbose. They speak a lot when I ask them a question. And you will notice that I interrupt them often. So here's what I'd like you to do when I interrupt. You need to stop interpreting what that patient is saying because I will keep on interrupting them until they stop. So those are different things that you would like to know before stepping into this environment, because otherwise you need to clarify this during the encounter, which is not ideal. I love mental health care providers that take the time to give me this additional information before I step into the room. And I do find that mental health care providers are more amenable to meeting with me before stepping into the room, whereas a lot of times medical providers will just brush past me or say, I'm kind of in a hurry, can we just get this over with? Whereas mental health care providers generally tend to be a little bit more considerate in that regard because they know just how important it is. Again, just something that I have noticed anecdotally, not necessarily a hard and fast rule. The last part of the conduit role, and this is why I mentioned the pre-session first, because the pre-session can really mitigate a lot of the problems that come up in this additional responsibility that is kind of at the tail end of the conduit role, but also blurs into the clarifier role a bit. And that is managing the flow of communication, or as I like to call it, the conductor. Might not be the best term, but let's just say for the purpose of this presentation, when I say conductor, I mean that is where you're managing the flow of communication. I almost like to call this the true second role of the interpreter, and saying that there are really 5 roles that of the medical interpreter. Sorry, NCIHC. But this is just a personal take of mine, my opinion. Now, this is the most involved aspect of the conduit role, and it can blur into the clarifier role a little bit. And it can involve a whole bunch of different things when it comes to managing the flow of communication. So how do we manage the flow of communication? If only we could use the Force, like a baby Yoda, to get people to do the things that we'd like them to do, right? Well, positioning is one way that we can manage the flow of communication. If you notice the patient is speaking directly to you and not to the provider, despite repeated interjections and suggestions to get them to speak directly to the provider, positioning can help you with that. Now, we all know that we have those patients where no matter where we position ourselves in the room, the patient cranes their neck to look at us. We can try our best, but it's not always possible. But you still have to try. Slowing a speaker down. So we often do this through third-person interjections or using sort of these minimal verbal expressions or nonverbal cues that the speaker needs to speak slower. It might be putting up a hand. So that is another way that we manage the flow of communication. Also, stopping a speaker to give you a chance to interpret. Sometimes patients, providers, they tend to ramble on and on and on. And while this can be mitigated in part by a thorough pre-session, sometimes we have to pop back in and remind all parties that, hey, you need to give the interpreter a chance to interpret. I actually really like it when patients do this or when providers do this because it's almost like they forget that I'm there. And they always say that the interpreter is supposed to be invisible. The interpreter is supposed to be a fly on the wall. So if they're forgetting that I'm there and just continuing to talk, well, I must be doing a good job, right? At least that's what I tell myself to feel better. And again, third-person interjections. You can do number 3 here, to stop a speaker. That can be done with nonverbal cues, but a lot of times it needs to be done through third-person interjections. So Baby Yoda says, you will speak directly to the patient in first person. So it's very important that if you are utilizing touch as a nonverbal cue, either to get a speaker to stop speaking, to get a speaker to slow down, that you exercise caution. It's worth noting that it is probably a good idea to set forth expectations for touch when trying to get a speaker to slow down or to stop or whatever, what have you. Likely a good thing to include in your pre-session, especially if a patient is a survivor of sexual assault, a survivor of abuse, even a survivor of torture, if your patient appears to be aversive to physical touch, or if your patient is sensitive to touch. Because utilizing touch in these situations, in these patient populations, can actually inflict trauma, can actually make patients be very uncomfortable, or even rattled, or even send them into a fit of panic. Because a lot of times, these patient populations are seeking mental health care, and you are interpreting for them. So you need to be mindful, you need to be considerate, and I would even say, if you know nothing about your patient going into a mental health care encounter, it still might be worthwhile to mention the nonverbal cues that you typically utilize. I have worked with survivors of sexual assault. I have worked with sex workers who are survivors of sexual assault. And I typically do not engage in touch as a way to interrupt or to stop the encounter or to encourage someone to allow me a chance to interpret for the first session that I have with a patient. Now, if I find that those other nonverbal cues outside of touch are not working, I may have kind of a mini meeting with the provider and the patient and ask them either before the session or after the session, even having a pre-session with the patient sometime, asking them, okay, well, for our next session, if I'm going to be interpreting repeatedly for this patient, how would you like me to let you know that you need to allow me a chance to interpret? Is it okay if I maybe lightly tap you on the shoulder? Because I did try to raise my hand. I did try to interrupt in third person, and you continued speaking. And I just want to make sure, and of course, you don't want this to be adversarial. You don't want to sound like you're blaming the patient, but I want to find an effective strategy that works because I want to interpret the very best that I can for you so you get the care that you need. Or even meeting with the provider and discussing this with the provider. And then maybe the provider will come back with you and the patient and kind of guide the interaction, and all three of you can work as a team to really find a good way to manage the encounter.
If instead of using touch, you decide to engage in a third-person intervention. A third-person intervention is, of course, where you switch to third person and state the interpreter would like to, or the interpreter, etc., etc., etc. So here are some common third-person interjections in medical interpretation. So the first is speak directly to the patient or the provider. The interpreter would like to remind the provider to please speak directly to the patient. The next is requesting a repetition. If you just didn't hear what was being said, or perhaps you think you heard what you thought you heard, but you're not exactly sure. And in over-the-phone interpretation or video remote interpretation, a very common interjection is the interpreter cannot hear the patient or the interpreter cannot hear the provider. Another common interjection is everything that is said will be interpreted. So ideally you would like to cover this in the pre-session, but as, well, I'm sure a lot of you know if you've ever engaged in medical interpretation, which I certainly hope you have, we don't always get an opportunity to do that pre-session. A lot of times providers will brush past us or interject, cut us off, and just cut straight to the chase. Not ideal, of course, in mental health interpretation. We would definitely want to do a pre-session wherever possible, and this is something that we should cover in the pre-session. However, oftentimes we have to step into these third-person interjections to remind people of these sort of ground rules that we have when interpreting. And this is a third-person interjection that I employed a lot when I was working at a local free clinic. Part of my job description was referral coordinator, diagnostic imaging coordinator. So even sometimes when I would step into these rooms to interpret and put on my interpreter hat, the providers would try and ask me questions that were not related to my role as an interpreter. And I would have to switch to third person and remind the provider that I was there in a capacity as an interpreter. And some common situations that I've been in as strictly a medical interpreter and even as a mental health interpreter is being expected to sometimes calm children. I would have patients ask if I could rock their baby stroller or hold a toy up for a child. And at that point, I have to switch to that third person role and say, the interpreter would like to remind the patient that the interpreter is here only to interpret, not to XYZ. So these are all common and allowable interjections in medical interpreting. But in terms of mental health interpreting, it's a little bit different. I would say out of all of these here on this slide, the most important, in my opinion, and the most commonly used in mental health interpretation, at least for me, is to please speak directly to the patient or please speak directly to the provider. So in medical interpretation, we are there to facilitate understanding, of course, and while the relationship between the provider and the patient is important, and facilitating that relationship by encouraging them to speak directly to each other is important, I would argue that it's far more important in a mental health environment. It's very important to nurture and facilitate that relationship and to allow that relationship to shine through because that level of rapport is very important in mental health environments. In mental health interpretation, you really need to exert caution when interjecting. And the first thing that you need to exert caution with is asking for repetitions. Asking for repetitions, of course, gets sort of into the clarifier role, especially if you are trying to clarify something, trying to understand something a little bit better. But the fact of the matter is, utterances change when they're repeated. If you ask a patient to repeat something that they just said, they're probably going to change it a little bit, summarize a little bit. They might leave out important information. And we've likely all experienced this when engaging in medical interpretation if we've ever asked for a repetition. You think you heard something, but you want to make sure that you got all of the utterance, so you ask for a repetition. I found myself doing this more when I first started out interpreting. And I began to discover that what the patient then said as their quote-unquote repetition was different from what I had initially heard. Now, I couldn't tell you in every single way, give you a play-by-play of exactly how it was different, but I knew it was different. This also, of course, holds true in mental health interpretation. What the patient says when you ask them to repeat it might be a little bit different, and that can actually have some pretty huge consequences. So let's say a patient discloses that they are feeling very depressed. And in that utterance, they also are dropping some clues that they might be inclined to self-harm. You don't think you got it completely when you heard it, so you go back and ask for a repetition. And then when the patient repeats it, they only repeat that they are very, very depressed, leaving out the important tidbit of information that they were inclined to engage in self-harm. That is where asking for repetitions can be harmful. Definitely ask for repetitions if you need them, but just be very, very aware that asking for a repetition can result in something completely different coming out of the patient's mouth. And something else we really need to consider, this gets into the concept of trauma-informed care. I will be dedicating an entire section of this series on trauma-informed interpreting. But asking for repetitions, especially if the patient is sharing something emotionally charged or even recounting a traumatic event, getting them to repeat that can actually inflict harm on the patient, making them relive what it is that they are describing. That can cause harm to the patient. So you have to be really aware of striking that balance between, should I ask for a repetition Or maybe should I switch into simultaneous interpreting mode if I feel like I'm not getting everything if I'm interpreting it consecutively? Or maybe you need to work on your note-taking skills. These are all considerations that we need to take into account when we're engaging in mental health interpreting. And this is just another example of an interjection that can be problematic, not just in mental health interpreting, but also in medical interpreting. Reminding all parties that everything will be interpreted. Remember that relationship between the mental health provider and the patient is very important. Damaging that relationship can inflict harm on the patient. And unnecessarily repeating or extraneously repeating that everything will be interpreted, that might cause some friction between the patient and the provider. If the provider is, for instance, saying something in the presence of the patient that they are not allowing you to interpret, it causes the patient to maybe lose some faith in you for not interpreting what is being said. There's a lack of transparency there. So, as I said, saying everything will be interpreted, switching into third person and interjecting and reminding everyone that everything will be interpreted can potentially be adversarial. And it can also be distracting. When I mention this, that everything will be interpreted can be a problematic interjection. This is why it just underscores the importance of having a robust pre-session when going into mental health encounters. Because 9 times out of 10, you can avoid these issues by having a thorough pre-session. That's not to say that you won't have to repeat these things, but it can help you to mitigate some of these issues. So we're moving away from the conduit role and we're finally stepping into the second role, which is the clarifier role. And I thought as I like to call it, the conductor role or managing the flow of communication, it kind of bleeds through from the conduit role into the clarifier role. So the clarifier role is intervening when you need to facilitate understanding, when you're really trying to figure out what it is that's being said in order for you to interpret it accurately and completely. So that can be in the form of these, again, third-person interjections, asking for a repetition. It can be just trying to make sense of something that was said that might be nonsensical, or even just dealing with unknowns. So if an unknown term or concept comes up, or you don't understand an idiomatic expression. Now, I would argue that the vast majority of this can be mitigated with proper preparation, proper continued education, especially the dealing with unknowns. If you come across a term you don't know, that indicates that you probably need to study the terms more in this area, whether it be in your source language or your target language. And then idiomatic expressions, you're going to come across them. And certain cultures use them more than others. But I will tell you, we fail to realize just in English how many idiomatic expressions we use. And it's very important to know how to interpret those, whether it be interpreting the meaning behind an idiomatic expression or knowing an equivalent in the target language. That can be great, especially in a mental health interpreting encounter where, again, you really want to make sure that you are properly facilitating the relationship between the patient and the provider. But should you clarify? Of course, you want to clarify when necessary, but in mental health interpretation, there are certain instances in which clarity is just not possible, and trying to seek clarity can be distracting. And when you need to take a time out to ask for clarity or to try and clarify, that distracts from the point of the mental health encounter. Of course, again, it's a delicate balancing act. You need to do it when you need to do it, but you also want to minimize your need to do it. It's kind of a tough spot to be in. So you have to ask yourself, is clarification really necessary in this moment? You need to really approach clarification with more scrutiny in mental health interpretation because lack of clarity can actually be a diagnostic tool. Patients with some psychiatric disorders just might not make sense sometimes. In a medical setting, it's very important to clarify meaning, to really boil down to, okay, well, what are the symptoms that the patient's having? Or how do we need to describe this treatment to this patient? But lack of clarity in mental health interpretation can be this important diagnostic tool. And this is actually something that mental health interpretation has in common with neurology because certain neurological conditions can also result in a lack of clarity. And so the therapist has actually worked with a patient before in a mental health setting, and not just a therapist, it can be a psychologist, a psychiatrist. They may actually be familiar with the things the patient talks about that just might not make sense to you. So I have some things here. Now, this is not an all-inclusive list, as most of my lists are not, but these are just some examples. So you can have patients that have some irrational statements. You can have compulsive lying. You can have patients with delusions of grandeur. You can have nonsensical speech. And then, of course, you have paranoia. These are some of the things that patients will say, especially in an acute or inpatient setting, that might not make sense to you. And while in medical interpretation, your first instinct will likely be, I need to clarify because I'm not getting something here. In mental health interpretation, you have to accept to some degree that there are going to be unknowns, and that is not going to lend you to clarification as much as in medical interpretation. And clarity just isn't always possible. It's just not. If a patient is engaging in nonsensical speech patterns, can you really gain clarity from that? Will you be able to stop the patient and ask the patient in third person? The interpreter would like to clarify what the patient says, then turn to the patient and try and clarify what they just said. Are you really going to be able to clarify what it is that they just said? I actually once worked with a patient who believed they were the second coming of Christ. So they would mix bits and pieces of biblical quotes into regular everyday speech, and it would be very strange. I was not able to gain a pre-session with this patient. I just wasn't. It was an inpatient acute situation, and it was very rushed and it was not ideal. But I made sure to interpret everything that the patient said, even though it wasn't making any sense to me. And the provider just seems to be accustomed to this. The provider was aware of this. So if I had summarized, though, the provider may have missed out on some valuable diagnostic clues. Okay, well, how deep are they in their delusion right now? Interpreting all of these things helps give the provider some of these diagnostic tools that they need. But if I had clarified, we would have gone down the rabbit hole. We would have had the patient describing their entire worldview and deconstructing the tangled web of their delusions, which is just not our job as an interpreter. That is the therapist, the psychologist, the psychiatrist's job, not yours as an interpreter. So we're moving along in our roles here. We're going to move on to the cultural broker. Like I said, the first role was the one that we were going to spend the most time on because that's where we spend most of our time as a medical interpreter and as a mental health interpreter. And as we progress through these roles, we really need to exert more caution before stepping into these roles. So we're going to be spending less time in these roles. And as such, I'm going to spend less time talking about them. That being said, this particular role, I actually have a later section in this series that touches on cultural perceptions of mental health and how to navigate those as an interpreter. The cultural broker role is facilitating communication by communicating cultural issues. First two roles aren't enough to facilitate understanding. There may be a cultural component that could be impeding understanding. And this is, of course, the second most involved role because it's second from last. And you really need to use your best judgment when stepping into this role, really when stepping out of the conduit role. And you really need to evaluate this on a case-by-case basis. So a very common situation that I've interpreted for so many times where I've had to step into the cultural broker role as a medical interpreter. This is my example scenario. The patient is non-compliant with their medication. So in my case, because I'm a Spanish interpreter, the Spanish-speaking patient is non-compliant with their diabetes medication. The provider repeatedly emphasizes to the patient the importance of taking their medication, and they're becoming exasperated that the patient just doesn't seem to get it. The provider cannot get through to the patient, and the patient repeats over and over again, well, my blood sugar has been getting better. I've seen this so many times, and it's kind of a signal to me that there's likely some cultural beliefs in play here, because there's a very common cultural belief that I encounter when interpreting for Spanish-speaking patients, especially from Central America, that is playing into this. Now, this isn't always the case, but I notice a difference between working with providers who are accustomed to working with the Spanish-speaking immigrant population from Central America and providers who are not. Oftentimes, providers who are not accustomed to working with that population they just become frustrated and they just don't understand. They're missing a vital piece of the puzzle. So health literacy and understanding plays into this as well, which that is also a cultural issue. Because of the culture, because of the country that person comes from, they just don't have the same level of health literacy and understanding of disease as a typical, let's say, United Statesian, as I like to call them, one of us who's born here in the United States might have. So a patient like this, a Spanish-speaking patient, may very well believe that they've been cured of their diabetes, that they just have to take their diabetes medication until their diabetes gets better, and then they're cured of their diabetes. Then comes into play this general cultural stigma against taking medications. So both of these things combined may result in the patient's stopping taking their medication after those symptoms disappear. Of course, you always want to respect the patient's autonomy and allow them the opportunity to express these things themselves. And you also want to give the provider an opportunity to dig deeper and really understand. But if you're finding that that's not happening and you're really, really convinced that there's a cultural factor in play, it's you likely need to step into this cultural broker role. And this may not always be the case. It may be something else. But it may be worth mentioning it to the provider in this situation. But even in medical interpretation, stepping into the cultural broker role is muddy waters, as I like to call it. And it's the same in mental health interpretation. You're getting into very muddy waters here. These waters get very muddy very quickly. And this is why this is a more involved role. And an interpreter should definitely exercise caution when putting on their cultural broker hat. Something else that interpreters need to take into account is the fact that culture varies over geographical regions. And even if you belong to the same culture as the patient, even if you're from the same country as the patient, your experiences and cultural values may very well be different. Again, muddy, muddy waters. As a mental health cultural broker, is it culture or is it something else? In medical interpretation, yes, we do have to exercise caution when stepping into these more involved roles. But again, like I said at the very beginning of this presentation, even more so in mental health interpretation. So you have to ask yourself, is it really the patient's culture that's contributing to this belief that they may have, or the reason why they're acting the way that they're acting, or is it something else? So of course, we have a patient, and just some things that I thought of that make up a patient that might motivate their actions. So their thoughts, their feelings, their experiences, their identity, these are all things that affect and inform their decisions, their choices, their actions, their behaviors. But in the realm of mental health interpretation, there's something else that's informing that may be affecting the way that they are acting or the behaviors that they engage in, or even the thoughts or feelings that they have. And that is a mental health disorder. So, of course, a mental health disorder can definitely affect someone's thoughts, can affect their feelings, and it can affect their experiences. But also, a mental health disorder, especially if it's a chronic mental health disorder, can affect someone's identity. Someone's mental health disorder might be so central to their identity that it's just part of who they are in their eyes. So, is it culture that's affecting the decision that the patient's making in this moment that you think might be culturally motivated? Is it their thoughts? Is it their feelings, their experiences, their identity? Or could it very well be their mental health disorder? It's a tangled web. And then we add in culture, right? So let's talk about culture. We're talking about mental health. Let's talk about culture now. So my culture, I'm American, United Statesian, as I prefer to say. So do I identify as American or United Statesian? I suppose. It's not really a central part to my identity, but it definitely informs some aspects of my identity. My culture also informs my thought. It affects the different schools of thoughts that I subscribe to. And it can also affect how I express my feelings and how I conceptualize of certain feelings. I have different experiences for having been born in the United States. Being born in the United States affords me a lot of privileges that maybe my patients don't have because of where they were born. So is it culture that is affecting the thought process of this patient, or is it their mental health disorder? It's very difficult to untangle this web. And then we add in something even more difficult. A patient's experiences are going to change their feelings, are going to change how they feel about certain things. So if a patient is a survivor of abuse, they may not like it when someone else is yelling. because it reminds them of an experience that they had in the past, or many experiences they've had in the past where someone was yelling at them. So it affects that patient's feelings when it comes to hearing someone raise their voice. But also, our experiences make up our identity. The experiences we have in life, me as a Spanish medical interpreter, that's a big part of my identity. So those experiences that I have as an interpreter shape my identity. And our experiences also impact our thoughts. If you're noticing a pattern through your experiences, your brain might make a shortcut. Your brain might say, okay, well, I see person of group X doing this thing. I've witnessed this thing many times. So now you see a person who belongs to group X, your mind automatically jumps to, oh, that person's going to do that thing, aren't they? And you might start drawing conclusions from that. So again, is the patient expressing a thought, a feeling, recounting an experience, or describing their identity? When they explain those things, are they explaining them through the lens of their culture? Are they explaining them through the lens of their mental health disorder? Are these thoughts that this patient is having the result of their culture, the result of their mental health disorder, or a result of their experiences that they've had? And then it gets even more complicated. Our feelings can affect our experiences. Have you ever had one of those days where you just wake up in the morning and you're just like, okay, I'm having a bad day. I'm just in a bad mood. And that sets the tone for your day. So then you experience your day differently based on your feelings. And that can be true for any one of these things. Your feelings can affect your identity. Your experiences can be affected by your thoughts, by your identity, all these things. It's a very, very tangled web. So it's really hard to pick out culture as the thing that is the determining factor for any one of these things that a patient is expressing. And I use this very complicated diagram to just really emphasize the fact that it is complicated. This is a very complicated role. It's very complicated to pull all these things apart and to really hone in on why a patient is thinking, feeling, acting a certain way, or why they had a particular experience. Was their experience typical of their culture? Or was their experience shaped by their mental health disorder? Sometimes you can't tell the difference, and you can't presume to tell the difference. That's not saying that you don't step into the cultural broker role. It's just that you really have to recognize that you may not always be right. So you can't make assumptions. You can't just assume that, okay, well, this patient is very hesitant to receive mental health care services. Well, that patient is from El Salvador, and El Salvadorians generally have a big stigma against receiving mental health services, so it's got to be their culture, right? And then you go and you explain that to the provider. You can't make that assumption because it can be any number of things. Perhaps the patient is feeling paranoid as a result of their mental health disorder. And that is what's preventing them from seeking mental health care services. That's where their hesitation is coming from. Maybe their experiences that have nothing to do with their culture. Perhaps those experiences are informing their hesitation. So you cannot make assumptions. It has to be abundantly clear before you step into this cultural broker role. And as I said, a further installation of the series really breaks down in even greater detail this role and explains how mental health and culture intersect. And our very last role is the advocate role. This is the most involved and controversial role. So it's all about mitigating harm. If you feel harm is about to befall your patient, or that your patient is actively being harmed, that's where you'd step into the advocate role. But what level of harm? Right? And that, I feel, is where the majority of the controversy around this role comes into play. It's not black and white. It's not. It's very much based on the individual interpreter, and it should be informed by the code of ethics, the interpreter code of ethics. And different interpreters have different, what I like to call harm thresholds, right? This should ideally involve the ethical decision-making process. The NCIHC actually gets into this with a great deal of detail. That's probably one of my favorite resources for really breaking it down when you should break into this advocacy role. I could dedicate an entire CEU series, not just a CEU course, but a CEU series to this topic. So I'm just going to refer you to the NCIHC's National Code of Ethics for Interpreters in Healthcare. because it walks through a variety of ethical scenarios and weighs different values in determining the best course of action. Different interpreters have different harm thresholds, as I like to call them. So, an interpreter with a high harm threshold will be an interpreter that will only intervene when there is a situation in which the patient's life is in danger. So my example here is when a provider is about to prescribe a medication a patient is allergic to. And this also include required disclosures. So in certain states in the United States, you're required to disclose when a patient discloses abuse. So that would be stepping into the advocate role. An interpreter with a medium harm threshold will, of course, do what the interpreter with the high harm threshold will do, but it might be a little bit more vague and ambiguous. It might not be immediate physical harm, but it might be something like a provider starts slinging racially charged terms at a patient. So a provider is acting unethically. A provider is really stepping outside of their role. The patient is about to undergo or is currently undergoing intense emotional and psychological harm. So an interpreter with a medium harm threshold will step into an advocate role in a situation like that. And then we have our interpreters who have this very low harm threshold. So anytime something comes up that the interpreter feels is unfair to the patient, they might step up and speak up. So the patient is provided documents and not in their language, in English. And the interpreter decides at that point to step into the advocacy role and request copies of those documents in the patient's language. That was the example that I thought of, but I can think of so many other examples and interpreters that have even lower harm thresholds. Of course, these interpreters will also intervene in these medium harm threshold situations and these high harm threshold situations. So it's going to vary by interpreter. It's going to vary because different interpreters are going to interpret the ethical decision-making process in a different way, and the interpreter might value some of those core values as outlined by the NCIHC more than others. So their own personal beliefs might be playing into the situation without them realizing it. So this next slide is especially geared towards those interpreters who have a low harm threshold, but is definitely something that all interpreters should keep in mind. So when you should not advocate versus when you should advocate. Interpreters with a low harm threshold, as I like to call it, it's very important for you all to realize that some degree of discomfort and what might even seem to you like the provider inflicting psychological harm on a patient can be part of the therapeutic process. So some degree of discomfort can be part of the therapeutic process. I have seen interpreters, or I have heard of interpreters interjecting, where a provider asks a patient a question that makes them start crying or sobbing, and switching even to third person and asking the provider to stop. That is not your job as the interpreter, because some of these are therapeutic techniques. Sometimes patients have to disclose things that aren't fun. They're not pleasant. They're not happy, but it's part of the therapeutic process. So some degree of discomfort, like crying, yelling, screaming, even resisting the provider. Now, I'm not talking about physically, though in some cases that might actually happen, which I will get into in a moment. But resisting the provider. If a provider asks the patient a question and the patient says, "No, I'm not going to answer that question," and the provider insists again, and the patient says, "No, I will not answer that question," it's not your turn to interject. You have to keep on interpreting. As I mentioned before, resisting the provider. Now, sometimes this may happen physically, especially if you're in an inpatient setting or an acute setting or a long-term care setting. Patients may end up being restrained or sedated for their own safety and well-being. It's very jarring, and these are all things that you have to anticipate, depending upon the environment that you interpret in. So what may appear to be harmful or jarring to an interpreter who is untrained in mental health scenarios may very well be the best course of action for the patient's benefit or the patient's health and safety. So when do you advocate? Well, there are some clear-cut examples of this. So if you have witnessed physical or verbal abuse by a provider or caretaker, you must disclose. Now, I say must, I say it's a moral obligation, and at that point, you must follow the reporting guidelines set forth by where you are located, by your employer if you're a staff interpreter, or your agency if you are an independent contractor. So I'm going to end this with saying that the advocate role isn't just for the patient. It's also for yourself, because as an interpreter, you are a human being. And as an interpreter, you need to protect yourself. You have to engage in self-care. and advocating for yourself is one of the best ways to engage in self-care. Now, I'm not saying to always advocate for yourself. I'm saying that there will likely present some scenarios in which you will need to put your foot down, in which unfair things will be asked of you. And I have unfortunately had to put my foot down and refuse interpreting assignments at certain facilities because I deemed those facilities unsafe for me to go to interpret at. There were not proper protocols in place. There was not proper security given the volatility of the patients in that facility. And I did have to put my foot down. So you may even have to dismiss yourself in the middle of interpreting for a patient if your safety is actively being compromised. Additionally, if you feel that you cannot emotionally handle an assignment interpreting for a patient, because this will happen, it may happen, and this happens in medical situations as well. If you have a family member who passed away from a medical condition and you're called to interpret for a terminal patient with that same medical condition, it might not be a good idea for you to interpret for that patient. You may need to dismiss yourself. In situations where you feel that your past experiences or even your values compromise your ability to interpret effectively, it is best for you and the patient, all parties involved, for you to dismiss yourself. As I said, advocating for yourself is one of the best forms of self-care. And there is actually a later part in this series that will touch on self-care for interpreters engaging in mental health interpretation. Thank you for joining me for the first part in this series. I hope you tune in for the rest of the sections. And I would just like to say that all of the photos that I used in this presentation came from pexels.com.